Well, first of all, let me say thank you to you. Thank you to all of you that are doing this most important work every day to increase safety for families and improve health and well-being. You're really why we're here. It's also my incredible honor to moderate this panel of friends and colleagues of many years and recent. That's you. I also think that this work builds beautifully on yesterday morning's panel that Dr. Marmot and friends facilitated on the social determinants of health. So I'm very, very honored to be the moderator for this really important work. So over the past year, we at the Robert Wood Johnson Foundation have been sharing our vision of building a culture of health with people all across this country. We have listened to others about their visions, and we have heard from many people who've talked about living in a nation where one's ethnicity, their income, their zip code does not hamper their ability to eat fresh food, live on safe streets, sustain emotional and mental well-being, and afford health care. People all across this nation envision schools and workplaces where instead of sitting all day, we can move around, remain active and involved in our own well-being and our overall health. So one of the most potent threats to this culture of health is the culture of violence that so many of us live in. In 1992, after a mere 40 hours, that time it was 40 hours, of training as a volunteer with a local domestic violence agency, I walked into a group of battered women, one of whom I'll call Marisol. So the first night of our group, Marisol shared that she was a police officer. She was married to another police officer, and what brought her to that group that evening is that her husband that very week had raped her at gunpoint. And when he fired off 2 shots from his gun, their 3-year-old son came running into the room. And so she had come to our group in search of a life for her son that wouldn't be the life of violence that she had grown up with. And she said, I couldn't do this for myself, but I'm gonna do it for him. And I was wholly unprepared for this group. The level of horror that women were living with, each of them had a story that was heart-wrenching. Each of them had a story of courage. But I was completely undone that first night by the level of complexity of their lives, really not only of their home lives, but of their neighborhoods, their communities, their lack of independence. Oh, hi. Yeah, they're louder. I gotta get louder, y'all. So much has changed. Vice President Biden, I loved his historic breakdown of the progress we've made. I am gonna get louder. So we've made a lot of progress.
We're competing.
And we have a lot to do still. Marisol and her son have stuck with me these many, many years. So while violence can affect all of us, and does, the research shows that children exposed to violence are particularly harmed, that violence when you're very young, for all of us really, can be toxic. So at the Robert Wood Johnson Foundation, we've turned our attention toward forming a strategy for preventing and mitigating early adversity in childhood and exploring how best to equip families with the building blocks for lifelong health and wellness. So here's what we know. We know that the healthy social and emotional development of children is heavily reliant on their caregivers and the other adults in their spheres. We know that the health of parents matters. We heard from Dr. Marmot yesterday. We know that the social and economic conditions of people's lives affect their health. We also know that the cumulative impact of childhood adversity can last long into adulthood, and especially as we think about this panel, for parents. But we also know this is not a life sentence. Many of us here are sheer living proof of that. The Adverse Childhood Experiences study demonstrated that having 4 or more ACEs in childhood was significantly correlated with an increase in chronic disease, poor mental health outcomes, increased risky health behaviors, and a reduced quality of life into adulthood. But as I said, ACEs can last a lifetime, but they don't have to. And it is never too late. So we know, you like that? That, by the way, is from Arizona's campaign. That's their communications tagline. We also know from the emerging science that the brain is plastic, that safe, stable, nurturing relationships not only promote health and well-being from the start, but they can significantly buffer children who have experienced adversity already. So the question then becomes, what do we do with all this knowledge? At the Robert Wood Johnson Foundation, we're asking the question, how can we know all of this, and how can it inform our vision to build a culture of health? So knowing what we know about the physical, the emotional, and the social toll that ACEs take on families and communities, how do we build into systems opportunities for families to thrive? How do we pair this narrative about adversity, which is really helping mobilize communities into action, with another narrative about individual and community resilience? And where and how can we most effectively intervene with both children and families in clinic settings, in mental health settings, behavioral health, in homes, in schools, in early learning settings, and in communities? So our hope is that this conversation will begin to answer some of these questions. Small toll, huh, y'all? No pressure. So this esteemed group of panelists, I know they can do it, will discuss a variety of ways that they have responded to ACEs, incorporating this knowledge into their practice. And we're going to hopefully have time to really talk about some of the opportunities and some of the challenges. I'm going to do really short introductions. They all deserve much longer, but we want to make sure we get time for their conversation and for your questions. I, of course, have a few. On your table, there are cards or there's notepads, so we encourage you to write those questions, and staff will go around and collect those, and then we'll have time to offer some questions to our panelists. So let me start with Dr. Nadine Burke-Harris. Dr. Harris is a pediatrician and the founder and the CEO of the Center for Youth Wellness in San Francisco. She is an advisor to many, including the Hillary and Bill Clinton initiative, Too Small to Fail, the governor of California. She's on several committees for the American Academy of Pediatrics. And her TED Talk, you can help, is nearing 1 million views in just 4 weeks. Nadine.
Thank you so much. It's a privilege and honor to be here to share with you a little bit about our work at the Center for Youth Wellness. I think most of you are pretty familiar with the Adverse Childhood Experiences study, but just as a very brief recap, the study was done between Kaiser and the CDC, using responses from 17,500 people about criteria of adverse childhood experiences, including physical, emotional, and sexual abuse, physical and emotional neglect, parental mental illness, substance dependence, parental separation or divorce, domestic violence, and parental incarceration. So those were the 10 traditional ACE criteria. And when they compared these to health outcomes, what they found was, well, there were 2 things about the ACE study that were incredibly striking, right? One is just how common ACEs were. 67% of the Kaiser study population had at least one ACE, and 12.6%, that's 1 in 8 folks, had 4 or more ACEs. And what was really important about that was, the other thing that they saw was there was a dose-response relationship between adverse childhood experiences and health and behavioral outcomes. So a person with a score of 4 or more ACEs had a risk of diabetes that was 160%, right? They were 1.6 times as likely to have diabetes as a person with an ACE score of 0. For cancer, it was 190%. For ischemic heart disease, it was 220%. For stroke, it was 240%. Hepatitis, 250%. Chronic obstructive pulmonary disease, 260%. Depression, 460%. Suicidality, 1,220%. So what we saw was this very, very strong and powerful correlation between exposure to ACEs and poor health outcomes. And again, the higher your ACEs were, the worse your health outcomes were. So for example, a person with 7 or more ACEs had triple the risk for cancer, 3.5 times the risk for ischemic heart disease, the #1 killer in the United States of America, and a 20-year difference in life expectancy. Now, for me, when I saw that data, because I was working in Bayview Hunters Point, a very low-income neighborhood in San Francisco, and I felt like the majority of my patients that I was seeing were being exposed to very high doses of adversity. And so understanding how these exposures were affecting their health, when we dive into the science, in order to be able to come up with solutions, we have to understand what is happening inside the brains and bodies of children. And so we looked at the science, and just very briefly, there are 2 really important pieces. One is the fact that high doses of adversity we know affects brain architecture, the structure and function of the brain. And one of the things that was really striking to me was that for folks who, the data showed that for folks who had very high dose of adversity, they had this increased risk of heart disease. But even if they don't engage in any high-risk behavior, that only attenuates about 50% of the risk, right? So if you have 7 or more ACEs, your risk of ischemic heart disease is 360%. But even if you don't smoke, you don't engage in any high-risk behavior, you're still at almost twice the risk of heart disease. And the reason for that has to do with the fact that exposure to early adversity affects your developing, not only the developing brain, but what we call the neuroendocrine immune axis. It develops your hormonal systems, and it affects your hormonal systems, and it affects your immune system, right? And so it affects the whole developmental trajectory of the child, and that's why we see increased risk for things like asthma, Alzheimer's, heart disease, COPD. Now, in San Francisco, what we did was we created the Center for Youth Wellness. And we started with universal screening for ACEs in the primary care home, right? The reason for that being is that when you think about a screening program, the goal is to identify when there is a latency or a time lag between exposure and the manifestation of an outcome, there's an invisible process that is happening, right? And in our case, there's an invisible process that's happening in the brains and bodies of our children. And the reason we screen is for 2 reasons. One, because it's a risk prediction tool. If I have a patient and their ACE score is 4, I know in my exam room when that child is sitting in front of me that she is at double the lifetime risk of asthma. I know that she's 2.5 times as likely to develop chronic obstructive pulmonary disease. I know she's 4 times as likely to be depressed. I know she's 12 times as likely to ever attempt suicide in her lifetime. I know that when she's sitting in my exam room. And so we can dedicate resources to addressing that. And at CYW, we do the screening tool for our kids who have 1 to 3 ACEs and no symptoms. We do anticipatory guidance. We educate, we counsel, we talk about the impact of adversity on health and development. If they have 1 to 3 ACEs and they do have symptoms, then we engage them in our services because they're already manifesting the adverse neurodevelopmental impacts. But if they have 4 or more ACEs and they don't have symptoms, we believe that the risk to their health is so great that we need to engage them in services. And so those folks will also get referred, and we can advocate to their parents, listen, your child has been exposed to X amount of adversity. Even though there may not be outward signs of it right now, we believe it's really important to get them involved with services to prevent a litany of poor outcomes. And surprisingly, we find that oftentimes parents get that rationalization. They understand that. And so for us, this screening in the medical home is part of our clinical treatment. It also helps us to understand, for example, if we have a patient and they have asthma and we're really having a hard time managing their disease, right? We understand because of the changes to the hormonal system that they may have somewhat of a different response to medications. So in our center, we use the screening tool as not only a clinical risk assessment tool, but also something that guides our management. Now, when we think about a public health response to something like adverse childhood experiences, it requires that we act on multiple levels. One is definitely raising national awareness. The second is investing in the research so that we can do more in terms of intervention than the current best practices. Our intervention includes home visiting, mental health services, biofeedback, mindfulness, exercise, nutrition. These are kind of the best practices, the current best practices that science tells us can make a difference on all the things that are going on for folks who are exposed to ACEs. But we need to show that it can be done. And that is what we are doing at the Center for Youth Wellness, is we are screening, we are doing our suite of interventions, and then we are tracking our outcomes to demonstrate as a national model that we can intervene and improve health outcomes. Martha mentioned my TED Talk, and since it's come out, I've had so many people reach out with their stories, and this was a letter that I just wanted to share really briefly. Dear Dr. Harris, I just finished watching your TED Talk on the impact of adverse childhood experiences upon lifetime health. I would like to thank you for the work you are doing in this area and for giving that talk. I'm a 37-year-old African-American woman who lives with 5 chronic illnesses, including asthma, which you mentioned. I survived every single ACE you spoke of in the speech. While I did not engage in risky behavior, I have received the blessings of a college education and have a successful career. I still live with the health effects of my past. As a Christian, I have forgiven much and gone on with my life with much counseling and prayer. But it was very vindicating to finally hear someone point out the connection between chronic illness and childhood trauma. Thank you for daring not only to learn, but also to take action. I am glad that the children at your wellness center will not endure the same struggle that I have and many like me have been through. Blessings. Thank you. That was shared from a woman in Texas who gave her permission for me to read that today. Thank you.
Thank you, Nadine. Wonderful. Are we showing the video first? No. Okay, you. Lana Davis. Many of you know Lana. She is the director of the children's program at Futures Without Violence. Lana is a survivor of domestic violence and has really been a central figure in this movement to build safety for women and their children for over 3 decades. She has created model programs that are used across this nation to help child welfare systems and others develop solutions to the problem of violence against women and child abuse. She has also co-founded the National Institute on Fatherhood and Domestic Violence. Lana.
Thank you. I'm going to stay right here if you all don't mind. I'm more comfortable sitting. Good morning, Rebecca. So good early Saturday morning, everyone. And I got a little permission from my colleague Lisa James to let you know that this could be the last Saturday that we have to wake up early, and that maybe the conference for the next time will not fall on our weekend. So I have to tell you the truth, there's a couple of things that I hate, and last night I was struggling with both of them, and one of them is waking up early. And the other one is public speaking. And so when those two things kind of converge, I was having my own little private adverse experience. And what helped me get through it, and I kept saying, well, how am I going to turn this into awesome, right? And the only thing that I could think of was all of you, and that you're here, and your dedication to children and families and communities really inspires me, and I want to give all of you a round of applause. So it's an honor for me to be up here with Dr. Burke Harris and Courtney Gray and Chris. I've only recently met Courtney, but I'm a big fan already. And I've been obviously following Dr. Burke Harris's work and Chris's for a long time. So what I'm going to talk about is guided by some principles that I've carried with me in the last 30 years, and I think are pretty consistent with the principles at Futures Without Violence. And the first is hope. And for those of you who do know me closely, you know that it's my middle name, so it's not hard for me to carry that one. But I believe in change. I believe things can get better, and I hold that really close to me. The second is empowerment, and that's something for those of you who've been in the field of domestic violence. It's something that has grounded us for a long time. Sometimes that word's been co-opted, but I think when we get back to what it really means, it's about a shift in power from I give you power to you have power, and I can help you facilitate that. And the third is compassion, and compassion for children and compassion for families, but ultimately for humanity at large. And when I think about childhood experiences and flipping that script to create awesome childhood experiences, which, by the way, one of our staff coined, Casey Corcoran, who's not here. I can't help thinking about a multi-generation approach. Some people call it a two-generation approach. Other communities and cultures might call it a 3 or 4 or 5, depending on how your culture defines a generation. But what I mean is that children don't live in a vacuum, right? They live within the context of their families, their communities, and their cultures. And so in the spirit of connected children, my value added here, I think, is how healthcare providers and other community leaders and healers can do universal education and provide simple anticipatory guidance. And with that, I want to show you a video which is a little longer than I wanted it to be. We worked kind of hard last night trying to splice and dice, but I'd like to roll it now.
This is a video made for parents and caregivers of children. We made it because when some people, including some healthcare providers, think about babies and kids, sometimes they forget to include the whole picture.
Parents and kids, we're kind of, well, let's just say it, connected.
And that connection is what this video is all about.
No parents were harmed in the making of this video.
But they did help us by telling their stories.
They shared with us some of the things they really didn't know they were signing on for when they became parents.
Lies.
Sleep.
Lovely.
Please.
Really, Mom? Come on.
I do. Lots.
I mean, you hear things about parenting. You think you know things. It's not true. It's like a delusion we all sign on for. Like, I knew babies cry a lot and didn't sleep, but that in no way prepares you for the totally slammed, exhausted, baby bouncer only shield against crying, because if you stop bouncing, you get crying, forget to brush your teeth phase.
And that's what brings us here. The kid thing, but through the eyes of the parents.
You're probably watching this because a healthcare provider, home visitor, or your kid's preschool
said it was cool, helpful.
Something they have started showing all the parents or caregivers.
Because who you are, where you come from, what happened to you, and how you figured it out.
it's important.
This video is about knowing that many, many parents were hurt as children themselves and maybe never got to talk about it.
I've spent a lot of time learning about what happened to me as a kid, what happened to me by my dad, what he did to me and how he hurt my mom. It shaped some of me.
Here's the deal. It's a fact that really ugly things can happen to parents and to kids, and that's not the end of the story. It's not the end. Many, many people come from hard situations and work through it.
Basically, parents can have triggers. They come up from behind out of nowhere.
Yeah, it's totally crazy. Like 1 minute everything's normal as a parent inside you, and then the next minute it's like a faucet opens up and you can't stop.
I mean, that's fine when it's just you, when it was just me, because I could figure it out. But then when I had a kid, I was like,
Wait, I have a kid crying. I'm trying to get my own stuff together, and how do I do both?
It's not like I hurt my kid, but there were those moments when I remember yelling at him to just be quiet. Because I needed to be quieter inside. I needed to deal with me.
So when they asked me to be in this video and told me what it was about, I kind of freaked out.
And I said, what?
what?
But in the good way, you know?
And then I was thinking, cool, right? Like, I get it. You're letting me know that this happened to others and not just me. And you're giving me the tools.
You got the tools.
Tools that build you up as a father.
I am a good parent.
I'm a good parent, and there are things that I can do every day, like
reading.
Play make-believe and tell them funny stories.
Hug them a lot.
my kid's life is different than mine was.
So seeing this, that talks about how what happened, when you grow up with that hurt, how it affects health, everything, I don't know, it made me feel more normal, you know?
I think to some extent, parents feel like, so if I had a bunch of bad things happen to me as a kid, are you gonna judge me?
Are you gonna judge me?
Are you gonna judge me?
Think I'm a bad parent?
That my kid should be taken from me or something?
I will say that the biggest thing is to see that what happened to me as a kid wasn't my fault. And I don't need to feel ashamed. And it doesn't define who I am today.
So it ends with a story that is our story of what we, that's me, and that's you, know about the difference, the essence of taking down shame. We flip it, turn it, watch it move until we own and see ourselves in this story, and our story, the one we tell, the home we make, the steps we take, and the difference for this generation, these children, this time.
All right. So I need to give props to Rebecca Levinson for the creation of that video and our health team. Thank you. So when I watch this video, I see people who are struggling with everyday stress, right? Crying, babies, not sleeping, you're not sleeping, but then you can see how that stress sort of exponentially just goes up, right, when you have your own histories of pain. And I think one of the things as a survivor is that one of the most painful things you can experience is the invisibility of your pain, right? So probably a close second would be being blamed for it. But the first is the invisibility of that pain. And so we want to raise that up. You have these cards on your table. That's the card that we were talking about in the video. And we love our cards at Futures. They are conversation starters, right? But if people, the ultimate goal is you can't replace the care of another person, right? And when somebody does want to talk to us about their histories of pain, we need to be ready and we need to be comfortable talking about it, because people feel us when we care and people feel us when we're just going through the motions. And that's on us and not on them. So we can give simple guidance to everybody who comes before us, and whatever your culture, whatever centers people in your culture, whether that's prayer or meditation or yoga or breathing, but it's something that we can all do. And then in closing, I know I've gone over, I'm sorry, I'll take up less time during the conversation. I want to make one more appeal, and that's that we work collectively to stop the violence and the adverse experiences that come in its wake. We need to strive to increase equity in our communities and share power with people. And when there are different rules for different people, systemic violence or structural violence or whatever you want to call it, it's real and it's not going away until we demand that it does. So the exposure to these experiences will not be solved with mindfulness or the healthcare field alone, but when we work collectively with other systems and in true partnership with community, I believe we can do it. Thank you.
Thank you, Lana. And that's a great segue for our next panelist. Dr. Christopher Lodgett is the director of the CLEAR, that's the Collaborative Learning for Educational Achievement and Resilience, the CLEAR Trauma Center at Washington State University. His groundbreaking work is focused on model development and the dissemination to help systems like early learning and K through 12 education become trauma-informed by adapting the science of resilience, brain development, and trauma treatment to educational practice. And one of my favorite Christopher Lodgett quotes is that trauma is not just one more thing on your plate, it is the plate. Chris.
Well, good morning. So I've worked around domestic violence issues for about 25 years. And it's interesting coming to speak to you because what I know collectively you've been doing for much longer than those 25 years is you've been making noise about the fact of domestic violence and the fact that things have to get better. We have to keep making noise. We have to keep making noise about adversity in the lives of children. We're here to talk about screening, and what I want to talk about in the little time that I've got available with you today is that I think that what we have to have is a trauma lens on the process and the significance of doing screening. That we have to understand trauma in order to be responsible about how we are able to talk to people about these issues. But that this is essentially a hopeful conversation. It's not a conversation entirely about loss, but it's about being able to talk about growth and change. One of the major consequences, and Nadine did a very nice job of summarizing a very complex body of work with the Adverse Childhood Experiences study, but when you look at that, here's one of the major consequences you take away from it, which is we swim in adversity as a culture. And for some of us, the water is very, very deep. When we start looking at this, we come often from a treatment lens, but many of us have also drawn the conclusion we've got to see this as a public health problem not as a diagnosable set of conditions only, that has an absolutely appropriate, necessary role. Spent a good portion of my life as a therapist on exactly these kinds of issues, but I know I'm only part of a solution. So our interest has been very much working in systems where children are, and that's what brought us into early learning and K-12 work. It's got us dipping our toe into healthcare. What I will tell you is we are not prepared systems, and we got to get prepared. We got to make noise inside of our own systems. As much as this process of talking about ACEs and the resulting consequences is about the things, mostly what we need to do is talk about trauma. And that means that we need to understand that where we occasionally get to be able to do things that are about changing the immediate adversity someone is experiencing, what we're primarily talking about when we open the ACEs conversation is a conversation about the process of adjustment and its long-term consequences. So, the trauma lens and how we deal with this. I want to talk to you very briefly about one of the studies that is still active for us. It's working with our Head Start in Spokane, Washington, which is a large urban Head Start system. We did introduce voluntary screening with parents about their own experience and their children. We've now done this with over 1,200 individuals where we have both parent and child paired ACE scores. And there are points where I find what we find with this absolutely terrifying. Because here's what I can tell you about Head Start in my community. And remember, with Head Start, the only qualification is you're poor. That's all that it takes. What we find is that over 60% of the primarily mothers that we used an adapted version of the original ACEs questions with report that they experienced 3 or more ACEs growing up. That puts them into this high-risk group that we talk about from the studies. But in these 4-year-old kiddos, 40% of the children have already experienced 3 more ACEs. That's according to the parents, and we think it's a conservative count as a consequence. What we also have demonstrated is that when we map the report of children's ACEs onto teachers' reports of school readiness, why is this important for you in a healthcare conversation? One of the single best predictors of long-term health is, did you graduate from high school? So how kids get ready for school really matters. What we found is that there is the dose effect on school readiness in 4-year-olds. We can demonstrate that the readiness, meaning the competency standards for pre-numeracy, pre-literacy, cognitive development, social emotional development, reflects the level of ACEs that parents report for their children. What we found is that to do this work, we had to slow way, way down because our colleagues in Head Start were not ready. And what we did is take almost a year to actually go through the process of installing the Screening Act into Head Start practice. It took us another year to get it to be fully functional. The resistance was never from the parents. The truth, I think, Nadine, again, you spoke to this as an issue. Parents go, well, it's about time. It's about time you're talking to us about these things. Because the essential truth of this is there. We're the ones who have not been prepared. What we had to do was get the Head Start staff who were going to be doing the screening to a place where they felt they could respectfully, confidently, and effectively open this as a conversation. So my argument about screening, particularly when we live in immersed adversity, is that screening is the door we pass through for much deeper conversations. I'm often very concerned that if we stop and we focus exclusively on screening, as important as it is we lose that basic human fact, that this is about relationship. Now, to do this through a trauma-informed perspective, here are the things that I think we really need to focus on. We know that the adaptive process of dealing with adversity is a very particular kind of trauma. And coming out of mental health treatments, what we refer to it as is complex trauma. So it's got a very specific way of being able to talk about what this represents. But here's what adversity does. It steals a basic faith in relationships. It steals essential ability to self-regulate at a developmentally appropriate way, whether you're a 3-year-old or you're 45, is that your ability to manage your emotions and not have them overrule you as you're trying to make good choices is put at risk. And it leaves with you an essential sense in your bones that the world is not a safe place. Those are the 3 thematic issues which we don't think you need to be a therapist to understand, but that any of us, whether you're a bus driver, the lunch lady, or a classroom teacher, can learn to use those principles to shift the experience, knowing the fact of adversity in the lives of children. So really appreciate the opportunity to be with you today.
Thank you, Chris. So finally, I really neglected to say that Dee Bigfoot was unable to join us for this panel, but we are so fortunate that Courtney Gray could step in. So, one crisis, one opportunity. Thank you, Courtney. So Courtney Gray is the director of the Trauma Response and Recovery Director of Trauma Response and Recovery at the Boston Public Health Commission. And while he was at Boston Medical Center, he co-authored a paper, Pathways to Recurrent Trauma Among Young Black Men, Traumatic Stress, Substance Abuse, and the Code of the Street. I would also venture to say that Courtney is certainly the most physically flexible person on this panel. He is the founder of Colombo Novo, which is a group of youth community members, clinicians, and agency professionals that use the Afro-Brazilian art form capoeira. You know what that is? They go upside down. To help people of color heal from daily ACEs and other traumatic events to reduce community violence. Courtney.
Okay, I don't know how you know about my flexibility, so. No matter what I plan to say before I get in front of a podium, it changes on walking up. And for me, what I'm stunned by and pleased by is the amazing compassion that this audience that I've got the chance to meet over the last 2 days, the amazing compassion that you all have. And for me, what's stunning is that the level of leadership in terms of programming and policy that we sit at. It's amazing. So I can go back to our communities and talk about hope on steroids, which I call faith. Meaning, no matter what the data looks like to us, we still believe something is, because the only way we could do this work. But I also am struck by another thing. Last week I looked at a graph or a map with 4+ ACEs indicated on it and saw my zip code that I grew up in. And I have to say, it was a sobering moment, because now I started flashing back to how many ACEs I experienced growing up as a child. But also what it takes for all of us to have chosen this work, and that they're real humans attached to the stuff we've been talking about, like a lot of death, a lot of suffering. I asked for permission if I could ask for a moment of silence to honor all of those people and honor why you chose this work. If that's okay, it'll just be a moment of silence honoring the real humans touched by our collective programs. So if you just put your head down a little bit, whatever faith you have, just a moment of silence. So I think the thing I'm going to talk about today is a set of experiences that I think shape my approach to what do you do after you find out that an ACE just happened. First, honoring the people that lived here before this building was constructed, before there was the concrete and steel. There were Native Americans here, and I believe they had an understanding of ACEs. ACEs have existed since humans were invented, and they might have developed some techniques on what you do if you find out that a mother lost her son to a mountain lion or falling off of a cliff. And I got a chance to learn some of these things from the Lakota tribe when I was in Lowell, Massachusetts. I just ran across someone, a medicine woman, and she said, "This is what we do. We've been doing this for years." I also have memories of what I learned growing up as a Jamaican boy and what we did when we found out that someone had a bad experience and they ran into my mom's house and said, well, they were basically presenting acute stress reaction. And most of the people in our house would say, this is what you do to calm that person down, to bring them back to homeostasis, though of course we didn't call it that. But what's interesting is when I started taking capoeira from the Bantu people who went to Brazil in the slave trade, They said you have to be initiated into our culture to be a teacher, but here's also how we handle the mind, body, spiritual, and emotional phenomena that happens when the bad thing comes. And for me, these things were consistent. So maybe 2 different continents of indigenous practices kind of were consistent in how you take care of this thing that has existed throughout time. So ACEs are not new, though this conversation about it is relatively new in my professional life. But things changed when I looked at a phenomenon that happened in South Boston. If you don't know about this particular part of the city, it at one point was the poorest city of white people in the country. And I think it's about 30,000 people, and over 8 months, there were 200 suicide attempts or emergency psych evals, and 8 completed suicides, all in 8 months. So this community was devastated. And I guess by accident or some fluke, there was a neurologist that started introducing the neurological reaction to these kind of exposures. And I'm talking about public incidents, like someone jumping off of something or doing something in a park. So this experiment led to some techniques and a deployable behavioral health practice that they experimented delivering into this neighborhood to say that in the real time, we're going to address what's going on in the community. And again, the techniques seem consistent with what natives said were happening and how you would respond. And then comes the research that I did with Dr. John Rich, who I have to name, who was the principal investigator on this NIMH study on penetrating injury and recurrent penetrating injury. As we were interviewing the men, they would say things that were shocking to us. So we asked questions that are on the PSS-4 instrument for PTSD symptoms. One very aggressive, big guy that I would be scared of if I saw him in a community, he almost jumped over the table and said, "Who wrote these questions?" I thought he was going to hurt me. And I said, you know, these are the questions we ask everybody. It's just us, Edna FOA, PSS-4. He said, these are exactly what I'm going through. Nobody's ever asked me these questions. Sleep disruption, how many times you've had flashbacks, intrusive thoughts, and so forth. He said, I'd gladly talk to you about this. And I said, well, would you see a therapist? He said, no, I wouldn't see a therapist. If a therapist came to the scene where my incident happened and said, how are you doing? Are you okay? I would say, I'm fine. I would lie. Not because there's something is not going on. It's I don't believe that institution has something to offer me. I think you guys have got it all wrong. I said, what do you mean? He said, well, first of all, I'm not the client. So why did you use the word client? Well, because you guys have been serving me all my life. You don't get it. I'm not the client. It's me, everybody who lives in my house, the gang I run with. If you take care of me, send me back into the community, I might be fine for a while, but their symptoms are going to splash back onto me. That was his term, instead of using transference and such things. So our ACE experience is contagious is another question, and who is the client, and who do we see in clinical settings? And how do we take care, if it is true that it is contagious, that it spreads, how do we take care of folks? So I believe, what I'm hoping for is that this ACE movement, first of all, thinks of multiplicity of a single ACE. So I saw 17 gunshots, but it only counts as a 1. And then somebody who had 2 incidents, but only singleton incidents, but in 2 categories, they count higher than me for some reason. And it doesn't count if I stepped over a dead body in my housing development. So when we really think about what it means to live in these neighborhoods, the multiplicity of incidents, and then what can we deploy in real time to stop this neurobiological, psychological process that starts in real time. And I believe there are deployable techniques that offer people the kind of services they get when they meet Dr. Harris in real time, but in the community. We have 40,000 young people we worry about in the city of Boston, each of which have high exposure to ACEs that need something the moment that process starts, and hopefully there's a way to start it, to stop that. And we do have one thing I'll leave on. Psychological first aid is one of those deployable skills, just like our CPR skills. Raise your hand if you know CPR or first aid. Imagine if our communities had that same saturation of a vetted, field-tested behavioral health technique so that wherever the ACE happens, someone within my reach knows how to turn that off. All right, thank you.
Thank you. Oh, you all made it so easy. There was no going over time. There's this huge flashing signal, but I'm actually too short. I can't see it. But I have my next 2 favorite quotes. One is Chris Lodgett, we swim in adversity, and for many of us, the water is very deep.
Yeah.
And Courtney, hope on steroids is faith.
Yep.
Thank you both. Thank you all. So, we've just heard, so we're really here to talk about awesome. How do we help children and families have awesome childhoods? And we've heard these 4 wonderful, rich perspectives. And I want to offer a couple of kind of overarching recommendations, maybe how we can think about it. So I think a couple things are clear. One is that it takes all of us. There's something any of us can do, no matter our setting, whether it's an individual level, family level, community level, or systems. There's, many levels that we have to think about this. We've also seen a couple of distinct approaches lifted up. One is screening in a clinical setting with appropriate and comprehensive services, and another is an approach of universal education. And so hopefully we can get into some of that discussion. So let me propose 3 recommendations, we can see if we agree, that would cut across disciplines, levels of intervention, and really regardless of where you are. So first of all, what I've really heard people say is we've got to focus on strengths and resilience. If you're going to ask families about their adverse experiences, you also have to ask them about their sources of resilience. Okay, good. So you're not going to be able to serve families well if that conversation is only about deficits. The second recommendation might be that we need to have a trauma-informed system and especially a trained workforce. So whether or not you're doing screening or universal education, if you're talking to families about trauma and adversity, you need to have some kind of training in trauma-informed care, practice, and approaches. These are very challenging questions and topics. I don't know how they ever let me do that for a support group. But asking them about traumatic experiences can really bring up traumatic memory. So once you open that conversation, you need to have the training to carry it through. And the third is that we need to focus our efforts on adequate community capacity. So before you start assessing or screening for ACEs, you ought to first figure out what you're going to do with them. What are the resources that families with high ACE scores need? And will you be able to help families access those resources? So I leave that for us to kind of consider as we go forward, and we'll see you back in 2 years on this topic, I hope. I've been coming to these conferences for forever, and it really is just such a great source of inspiration and new ideas. So let me start with the first question, maybe start with you, Nadine, and then we can go on down if people want to say. But so for Nadine, we've really looked at her center, the Center for Youth Wellness, sort of the Cadillac version. First of all, they have Nadine. Not everybody does. Yay! They also have a deep and rich understanding about trauma and the importance of not only traditional kind of best practices, but they're really on a frontier of seeing what else can we do when we identify trauma. And I'm wondering for you, what would your pediatrician, your recommendation for this, troop of people coming behind you who are in practice already at the community level? What can they do without that?
Thank you, Martha. I would say, a lot of people will say to us that we're like the Cadillac model, and I actually see our organization as more of the Tesla model, where we're a little bit more in the concept car phase, which is that we're really trying to figure out what can be done and what is the future that we want to see look like. And I think that there are some basic aspects of this work. I came to this work because out of my background in health disparities. And I was working in low-income communities, looking at primarily black and brown folks and trying to figure out why are we dropping dead of heart disease so much. And I think that the issue of ACEs, I love this panel. First of all, I just want to thank and congratulate my other panelists because we absolutely need an ecological model, right? This is not about, therapists have all the answers. I feel like our mental health colleagues have been sounding the alarm on this for decades. And my colleagues in primary care are just beginning to catch up because of the strong positive correlation between ACEs and chronic disease. I think at minimum, when we're looking in the primary care home, what we would hope to see, what we see in the future in terms of, from our team, is screening and an integrated behavioral health primary care model, right? So if you're able to screen, detect, and then plug families in for services. Now, for some places, we're not there yet with the integrated behavioral health model, so we're not able to get that full scope of services. And in those situations, at very minimum, you want to be able to refer families to trusted community resources who are culturally and linguistically appropriate and sensitive. And in fact, when we are developing our training about, for other primary care providers, we actually don't teach folks how to screen first. Step one is figuring out your response, right? Who in the community is doing this in a really thoughtful and effective way, so that, because I do believe that in every primary care home, we should be screening. By the time, let me say that, we should figure out how to screen, and where we want to go is to have screening part of the well child check. By the time a child is getting booted out of preschool for behavior problems, the neurodevelopmental impacts are already so profound that the child's neurologic function is being affected. And very similar to the data that Chris Blodgett and his team saw at the Bayview Child Health Center, for our kids who had an ACE score of 4 or more, their risk of having learning or behavior problems in school were 32 times those of children who had an ACE score of 0. Our Black and brown and some and Asian and Latino and Caucasian children in Bayview Hunters Point, where violence is the leading cause of early mortality, if they had an ACE score of 0, only 3% of them had learning and behavior problems in school. And if they had an ACE score of 4 or more, 51.2% of them had learning and behavior problems in school. And so rather than waiting for them to manifest symptoms, when we screen and then are able to intervene early to prevent the downstream effects, that for me is the gold standard model, and that means that we have to galvanize our community partners, our mental health partners. We're doing a training for the San Francisco Police Department. All of these things to be able to figure out how to do an ecological model that supports our children using the science and the data around ACEs and toxic stress.
Thank you. Thank you. Anybody else want to comment on that? Oh, I've got questions now coming. Okay. So, Chris, you want to take a crack at this? What interventions do you recommend for teachers and social workers in high-need schools where many of the students experience adverse events that leave a negative impact on their learning? Consider low levels of parent engagement.
So in Washington State, we're in about 20 schools right now across Washington. A number of them are very rural, central Washington communities that we're working in. So significant Latino communities. We have one school where parent-teacher conference nights are duplicated because they have to separate based on the gang affiliation of the children. Those schools have no external resources. This is fundamentally a question about, given the fact of this, what will you do? Because there is nobody behind you. You are the solution that's going to have to come. One of the kind of classic resilience articles is by a woman named Marston, and the title of it is Ordinary Miracles. And what she speaks to in this is that a lot of change is not about huge, dramatic, transformational events. It's about the steady bricklaying of what love and kindness and consistency can end up doing. So one of the things that we do when we start working with educators and we start working with people in other settings is we talk about the scientific basis of love. For somebody trained as behaviorist as I am, that took a little bit of growth on my side. But we're on really solid ground making this as an argument. So compassion is a real thing. It's a tool. What we train to is that we think that coming out of the complex trauma treatment literature, I mentioned that I really think that the conversation of ACEs is principally about this accommodative process of trauma, is that we have established recommended evidence-based practices, and from them we have distilled practices that come down to say, if you focus on these things, you can make a difference. And one of the fundamental issues is things like intentionally, specifically, work to increase predictability in the lives of the people around you. Put safety at the front of any conversation that you have. Not your sense of safety, but understanding the safety of the person that is across the table from you at that point. Teach to these issues. So this is not ours, this is actually from Daniel Siegel. So this is the group participatory part of my presentation. If you wish, you can raise your hand, okay? Roll your thumb in and your fingers over. This is the hand model of the brain. Spinal cord, central limbic system, prefrontal cortex. We teach and model for teachers to integrate it into science lessons. We teach the hand model of the brain as early as kindergarten. And it becomes a language for kids to be able to talk with each other and with their teachers about where they are. So what we talk about, what Siegel talks about, is upstairs brain, downstairs brain. And if you're in your downstairs brain, you can't learn. And if you're stressed, what you do is you flip your lid. We have kids and teachers who make contracts that a child who is really affected by trauma can end up looking at the teacher, make eye contact, and go like this. And it's permission to step out, to be able to take 5 minutes to reorganize, and then come back. When I talk to principals that we've worked with, does that then create a sense of privilege or stigma around a child? What principals tell me is, you know, children on the whole are very kind, and that they understand the need, and they don't think that it's an issue of somebody getting something special. We think a lot of this conversation is about terrible intentionality, about doing very simple things.
Great. Do you want to comment, Courtney? Yeah, good.
First, I want to talk about resilience. Sometimes I worry about the resiliency movement placing all the responsibility on the individual and the family. So I think that there are resilient environments. So my legs can be strong, they're resilient, they bend a little bit, but if you put a certain amount of weight on my legs, they can break. Might be good if I know what to do if I get a broken leg, but the fact that there is an EMS system that can arrive at a certain time and get me to the hospital at a certain time, that affects my ability to actually recover and bounce back. We do have some neighborhoods. The neighborhood I grew up in was right next to a very rich neighborhood. We were friends, people were commingling. Yet if I were in my friend's house, the response time was 12 minutes. In my neighborhood, it was 40 minutes. So whoever's responsible for creating the environmental resilience, including services that I have access to, we need that just as much as resiliency. But the school conversation is interesting to me because I guess in certain schools, particularly Boston, there is a response system when, for example, we found out that a kid has been murdered. And so imagine one of these tables is your homeroom, and we know that chair is going to be empty because a child is not coming to school because he was murdered. So imagine what Sandy Hook received as services. The fact that we have some schools that have those services in place, I don't really call it trauma-informed. I need another term for indicating that these services are wired into the behavioral health process, the student support process, where that homeroom and other impacted kids receive a set of services that help them. And also, those teachers and those support staffs, they're actually, I think, breaking some rules to make themselves more accessible to their students. Like, if I have a therapist and they become the person I lean on for tough things, am I allowed to call them when I think my mom is going to really start a fight with my father? And I'm going to jump in and protect somebody. Is there a number I can call? Well, most therapy system does not allow for that kind of boundary break. So the question is, who is the lifeline for that kid? And if something does happen, how do we tell the school staff, this kid was in a brawl with his own family member on a Sunday night, so he's not coming to school Monday, so don't penalize him, and Tuesday and Wednesday. And when he gets there, maybe you have a behavioral health process waiting for him instead of a penalizing process. Or often that kid will come to school and exhibit the predictable form of acute stress reaction. If a teacher waves their hand like this and doesn't have these signals, they're going to actually receive more stress, and he's going to blow out, and then he's going to get, in our case, arrested, as opposed to this other trauma-sensitive, trauma-informed, trauma-ready process that we have for them. So there's a lot of this sort of where does the care take place in the school as well. There's a lot we can do. There's already practice in place that we can expand on to create this environmental space, this ecological space that we're looking for.
Good, Nadine, yeah.
So I think that's 1,000% right on target, and part of the work that we do at CYW in thinking about how do we help to make the argument for that, right? Because everything that we just heard from Chris and Courtney, folks will say, well, that sounds delightful, but how are we going to get the money to do all that, right? And it's discretionary income. Well, this is, I think, a real part of the importance of where the medical community comes in. The good news is that we spend 18% of our GDP on healthcare, right? And so when we talk about services, the ecological model to change systems, and people are trying to figure out where the heck are we going to get that money from, heart disease is the #1 killer in the United States of America. We spend $2 trillion a year. 75% of that in our healthcare system, 75% of that is treating chronic diseases. ACEs are a risk factor that will either raise your risk of the 8 leading causes of death in the United States to 150 to roughly because suicide, 1,200%, right? From 150 to 1,200%. And one of the things our organization is doing right now is doing the economic analysis, because we look at it and we get, oh, education, okay, I get that. And then we get, okay, juvenile justice, I get that. We get, a bunch of these other things. If you take the major driver of healthcare expenditures and say, let's just take even 1% of that and invest it in prevention, in changing systems, in really establishing this ecological model, then I don't care which side of the aisle you're on, that's something that folks can get down for in terms of, because everybody is trying to figure out all these different ways of how we can reduce healthcare expenditures.
Thank you. Oh my gosh, this is the tragedy of the clock. I'm now tall enough to see it. All these great questions in no time. Let's see. So I think I'm going to ask one last question and have all of you respond to it, because, but I just want to say that there are some great questions here about mothers in partnership with the health system. Courtney, people want to know examples of psychological first aid. Another question about empathy for parents, changing social norms. It's very, very easy to despise and criticize parents who themselves have had ACEs, so how do we increase empathy? So there are a lot of really rich questions, and I think what that says to me is we have a lot of work and a lot of considering and a lot of thoughtful discussion to continue. But as just a question for the whole panel, what do you see in your communities, in your work, in your efforts as you travel and as you're thinking about this, sort of promising targets for system-level intervention to prevent ACEs? So I'd love to have a little conversation here about the prevention of ACEs, and it's sort of coming. So Chris, you want to start?
Sure. One way that I think you can look at this is to make the best of the fact that we live in evidence-based practice land, and that that is the environment that we end up having to deal with. But although it's gotten to be a lot better in terms of our level of understanding around these issues, here's the guilty secret about evidence-based practice. Mostly they fail. They don't reproduce the level of expectations of benefit, but they fail for understandable reasons. And what has developed almost from the inception of the evidence-based practice movement is a line of parallel work around what's called implementation science. And in implementation science, I'm seeing some heads nod, which is great, because I will tell you 3 years ago when this is one of the things I kind of take the flag and wave on, there were very few people who had actually heard about this. We're in a period of just phenomenal change right now in terms of our level of literacy and understanding around these issues. But here's some of the things that implementation science points out, and it is right to the heart of this issue about implementing change in any system that we're dealing with. If your leadership is not bought in, you're sunk before you start. Mm-hmm. If you have not ended up creating the conditions of readiness in terms of supervisory practices, in terms of kind of core foundational knowledge associated with this, you are unlikely to succeed. You have to build a sense of will among people about why this matters and is not one more damn thing. What we've learned to do when we work with schools is to look at the issue of readiness as the central thing that we need to deal with. We've learned, for example, that you can't have a brand new principal in a building trying to sort out their relationships with their staff and bring this conversation in. It's a timing issue. We need to be sensitive to timing. But one of the things that we've learned, which is again an uncomfortable conversation, and it's true in healthcare, which we also do work with, as it is in education, there are some organizational cultures that are not safe. They're not safe for the patients walking through the door, and they're not safe for the staff that are there. And until the toxicity is called out and addressed as a precondition for healing, we don't have an opportunity to deal with this. So fundamentally, to get to scalable prevention, we have to think systemically. We have to think about the health of the systems, and I think thematically you've heard that from all of us as issues to deal with.
That's very helpful.
Well, I'll just piggyback on that because I think it's partly what I see, and I would expand on it by saying that we need to work across systems, and so whether it's preventing ACEs in juvenile justice or education or healthcare or in communities, there's a real connection between those systems, and I don't think we're comfortable necessarily working across those aisles. So I would add that. And then the last part about our preparedness to do this work, I think fundamentally, creating empathy for parents or creating empathy for others really starts with creating empathy for your own experiences. And so when we can do that, we are much more likely to have empathy for others. So this isn't about an us and them. This is about all of us.
Great. Courtney, Nadine?
I'll say from our standpoint, I think that primary prevention really, what we see as an important aspect of primary prevention is national public awareness. We all remember those days where people used to smoke in the car with their 4 kids in the back seat with no seatbelts on, right? And then it was this the spreading of this awareness. A national public awareness campaign is really part of seeding the movement, right? We know that it's not just about what happens one-on-one between physician and patient or in the school setting or in the more grandmas that can look at their son or daughter and say, baby, don't you know that when your child is exposed to blah, 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 right? It affects their brain, right? Like the more of that happens, right? That's primary prevention, and that is, I think that's one of the most effective public health tools that we have. For us, we believe that if we get the word out, then and that we can create this movement, that it will also galvanize folks to find solutions in whatever sector they are in, right? I just recently spoke at the Google Women's Leadership Conference, and the number of people that came up to me afterwards, this was the 350 most senior women executives at Google. The number of women who came up to me afterwards and said, you know what? This is my history. How can I help? How can I use technology? How can I use media? How can I use whatever it is? Because when you have a problem of this scope and scale, it takes all of us to figure out how we're doing things differently. And so that would be, for me, the national public education, early detection, effective intervention, and we will see a change.
Okay, so first of all, I'm going to go back to that faith comment. So the fact that I actually have faith and I meet people who you can tell. Like if I meet a basketball player, this guy that says he can play basketball, you can tell by the way they act and move whether or not they really can play basketball. The people I've met here that are like committed to this work, and especially at this high echelon, I'm getting this serious feeling that people are connected to the work, that they feel it in their bone marrow. And I did not have this feeling like 5 years ago, 10 years ago, and I'm new to public health. I'm not trained in public health at all. I come from another industry. And so I literally are these people serious about trying to make my life better, my bloodline? How many people that look like me are in this room? How many people are in leadership positions? I can be really honest. What I really am hopeful about is this, though, is that I think the culture of the clinical setting is the only place where healing happens is now debunked. Like there's a barbershop you can go to in Boston, and if a guy says, I was arguing with my girl, and I thought she was talking to some guy, so I took that phone from her. I started going through her phone, and there's a barber there that will say, boy, what are you talking about? That is domestic violence, man. We can report you right now. The fact that black men have poor health-seeking behavior. Now, this is bad because I think people care about me while I'm in my mother's womb until I'm about 6 or 7 years old, and then there's this large gap until I'm 40 years old, and then they say, does he have prostate cancer? Let's do a digital. I'm like, literally. So how many ACEs am I creating for kids during this time period? And so the question is, do I have health-seeking behavior? Yeah, I have health-seeking behavior. I just don't seek this system. You call it stigma. Stigma says, you should change so that you start using the stuff we're doing or we're not changing at all. But if we use a different industry's behavior, like restaurants, it's like, oh, I want these customers to eat at my pork restaurant, but they're Jewish and they're Islamic. So I'm asking them to change their fundamental beliefs to use in my restaurant? No, I'm supposed to go out of business or change my whole style of restaurant. And here I get the sense that people are saying, we're changing the system to meet the consumer's needs, right? Call me a consumer, not a client. I have choice. Well, sometimes I have choice. If I lived in a certain rich neighborhood, I could choose the yoga studio as well as my therapist. But in the neighborhoods we see, the saturation of yoga studios nowhere near matches liquor stores. So if I want to take yoga, I can't. That's literally why we started bringing capoeira into the community, because this is a mind-body movement-based, where the neurologists that research it say this is known to stop the HPA axis from firing all these hormones in the body that will jack that person up. And we have gang members coming in saying, man, this class, I feel like I'm mellowing out, man. Literally, I'm like, you're supposed to go to a therapist for that. And we have therapists taking it with us so that now they have a therapeutic relationship, and then they start to, go up the ladder of engagement to really deep, high-end services that they really need. So a lot of these myths, I think, are being blown away. I just want to leave on this note. We are actually in a process of industry innovation, right? When we're done, this will look like a different industry from the one we joined, which is a typical process in other industries. Like, I used to have my first telephone was like the size of a brick. It had a long antenna. I was so proud. That thing, you can't buy it. You can't even buy your Motorola flip phone anymore. Like, those things have gone away. The industry is new. The old paradigm has collapsed. Just like when a caterpillar becomes a butterfly. The old thing has collapsed. We need to seek that level of change. for us to engage with our partners. And if we stop believing in this, we will never have what it takes to fight the fight that Vice President Biden told us we have been fighting for so long and still have so much distance to travel.
Well, that is the last word. Wow. Thank you, guys. Look. All right, my notes say we're going to watch a little video, but before that, I'm supposed to remind you after that to go to your next workshop right after they're starting. And I just want to say, really, this has been a great thrill. I can't wait to take this back to the foundation to share what is going on in multiple communities. And I really thank you so much, really, for the work that you're doing day in and day out to make things better. So, and to create this culture of health in the barber shop.